Okay. Thank you, Dan, for inviting me, and thank you, Sabrina and Marie. I apologize for those of you who have seen these slides already, because I gave this at the Florida Pediatric about a year ago. So we're going to talk a little bit about the PTSD. So I want to cover the history very briefly and some of the neurophysiology, because we have to know what we're medicating or trying to medicate. So the neurophysiology is very important. So starting with, if any of you saw the Ken Burns series on the Civil War, you may remember this. This is the Battle of Chancellorsville, and you probably remember that the Confederacy, independent of the moral issues, they did have the best generals. So this is Chancellorsville was where Stonewall Jackson got shot. There he is being shot over here. And so he lost his arm, and they had to amputate his arm, and he died of sepsis about 3 weeks later. And this is really the turnaround of the Civil War, where the Union starts kind of winning more battles because the Confederacy lost their best general. So Stephen Crane, who was at Chancellorsville, described the events in a novel that was mandatory reading in a lot of high schools, The Red Badge of Courage. And so the character, Henry Fleming, is somebody who breaks down in combat, has PTSD, and he runs away. He basically is a deserter, and another regiment finds him, and they think that he's the survivor of a big battle, so they think he's a hero, but in his head he knows he's a coward, or he feels like a coward that he ran away. So he gets a second chance, and in the second chance he's the flag bearer. He runs in front of the pack and they win, and so on. So here you see the beginning of the psychodynamic part of PTSD, identification with the aggressor and repetition compulsion. So you get traumatized, you want to go back there and do it again until you get it right. This is Audie Murphy, who played the lead role in the film, The Red Badge of Courage. And Audie Murphy was, in real life, a veteran of World War I, and he was the most decorated soldier in the American Army in World War I. But he suffered from very severe undiagnosed PTSD, so he died of complications of alcoholism in his early 40s. He suffered from episodes of depression, he couldn't sleep, and died of alcoholism, so he was never treated. So here you see in World War I, where Audie Murphy was involved, that the PTSD diagnosis was called shell shock, and the belief was that it had to do with the vibrations of the explosions, that it was the vibrations that caused the damage. And people were identifying PTSD, but they really didn't understand it yet. This is, you probably saw the Patton movie, the scene where he slaps the soldier with PTSD, and the doctor in the tent kicks him out. So I have a personal anecdote to share. The doctor who kicked Patton out of the tent was married to my mother-in-law's aunt. And he was an internist from Albany, New York, who got drafted to the war, and he didn't know who was who. So Patton showed up, and he thought that was preposterous behavior, so he kicked Patton out. So according to my mother-in-law, who's 93 years old, she said that her uncle was probably just as unpleasant as Patton himself, that it was. Anyway, they created a category, gross stress reaction. In DSM-2, they took it out without an explanation because there was the hiatus between the Korean War and then the Vietnam War, when the Vietnam War picked up. So during the Vietnam War, again, PTSD became very important, and it was introduced for the first time in DSM-3, and it appears as PTSD in DSM-3. The person who really described the neurophysiology was Hans Selye, and Selye was the person who coined the term stress, and he wrote this, very seminal book, The Stress of Life, and he talked about the general adaptation syndrome, and he was the first one that figured out the hypothalamic pituitary adrenal axis, and realized that when people are in an alarm state, it wears the whole neuroendocrine system down, and people start entering in a state of exhaustion and so on. So it was the beginning of understanding the neurophysiology of PTSD. So in terms of the classification of symptoms, this is the work of Lenore Terr in the 80s when she started looking at trauma in children. So she talked about single event trauma, or type 1, which had better prognosis, and type 2 complex trauma, which was ongoing and of long duration, and obviously it had a worse prognosis. And so then we have the 5 set of criteria to define PTSD. So the person has to have had exposure to an actual event that involved death, serious injury, sexual violence in one of the following ways. They could directly experience the event, witnessed it in person, or learning about the traumatic event from family members or close ones, so they didn't have to physically be there, or repeated exposure to adverse details about the traumatic event. One of my supervisors in my fellowship treated one of the Kennedy kids. I believe his name was David Kennedy. David Kennedy was about my age, and he died of an overdose of Demerol. And he was injecting Demerol between his toes. The supervisor told me, "Oh, you're from Miami, and then we talked about David Kennedy, and he said that he had been the treating psychiatrist, and what happened to David Kennedy was, Bobby Kennedy had about 9 children or 10 children, and this kid was 9 years old, and in the ruckus of the assassination of Bobby Kennedy, they forgot him. And he spent an entire day watching his father be murdered on television over and over and over, and ended up with very severe PTSD and a substance abuse problem. And so the repetitive exposure can cause PTSD. As it happened with a lot of kids in New York City, that were exposed to, the continuous images of the 9/11 events. So we look at the main criteria. So you have the intrusion symptoms, the recurrent memories of the event, the flashbacks that are triggered by internal cues. We're all familiar with that, and these trigger physiological reactions like sweating, palpitations, and so on and so forth. Then there's the opposite, the persistence, avoidance of anything relating to the traumatic event. So these are people who, may be averse to going on an airplane or getting on an elevator, or a classmate of mine from medical school who's a cardiologist, his wife had a brother who drowned in a pool. And so she never goes in the water. She goes to the beach and never goes in the water. She was very traumatized. I think she was 5 years old when she saw her little brother, drown in a pool in front of her. So negative alterations of cognition and mood associated with the event. So you have the amnesia's inability to remember, persistent distorted cognitions, Also in children, as you know, the egocentric causality, it was my fault, I must have deserved this. Persistent negative emotional state, so the irritability and the depression, the diminished interest and participation. As you probably remember, a lot of the Vietnam War veterans that came back with PTSD moved to Washington State, Oregon, and that part of the country so that they could live in isolation, because anything that was charged with too much stimulation kind of threw them over the edge. Feelings of detachment and persistent inability to experience positive emotion. So people are left with this chronic dysthymia as a consequence. These are children's drawings from the civil wars in Burma and in Syria. And they, this one over there, you see the chaos, the overstimulation, and then the very sort of jarring images on this one over here. And the marked alterations of arousal and reactivity associated with the event. So these kids end up with a lot of irritability, angry outbursts, reckless self-destructive behavior, hypervigilance, exaggerated startle response, and so on and so forth. We tried to do a study years ago with former Cuban political prisoners, and they had a lot of these behaviors, very self-destructive, very impulsive. They took a lot of unnecessary risks. These are some images of children exposed to horrible war situations, and we see this in the news every day. The DSM-5 has a new classification, the PTSD with dissociative symptoms, which include depersonalization, derealization, and with delayed expression. And then, of course, there's the acute stress disorder, which is mild PTSD symptoms, but lasting less than a month. Here you see the dissociation. Look at the smile on the little kids, and the scene where the parents have been murdered. This kind of reminds me of the Menendez brothers. I don't know if you remember the case of the Menendez brothers who murdered their parents. A little bit about the epidemiology. There's no national sample, national population sample, but there's some pretty good large studies. So the National Survey of Adolescents in '93, it had 4,000 adolescents, 12 to 17, and these are some of the things that cause PTSD: serious physical assault, sexual assault, etc. And this is what you see accompanying the PTSD. This is the classical sexual abuse. What's wrong with the picture? You could probably identify what's wrong with the picture. This is the little girl there. A little bit more about the epidemiology. There's more than 3 million reports of child abuse and neglect annually in the US. 1 out of 4 girls and 1 out of 6 boys is sexually abused in the US before age 18. That's pretty alarming. More than 90% of these children are victimized by someone that they know. And here's a real kicker. Florida is the second deadliest state for children. In 2011, the Child Protection Agency received 3.7 million referrals for children that had been abused and neglected, and the U.S. spends $120 billion annually, directly or indirectly, for situations that involve abuse. So a little bit more, it is estimated that 1,600 plus children in the U.S. died as a result of abuse or neglect in 2012. So the statistics go on, and the point is that it's a very common thing abuse and neglect in children. Here's a graph that shows how before the Vietnam era, PTSD was not identified and how it became identified right after Vietnam. So as soon as Vietnam put PTSD in the under the microscope, child PTSD became apparent. So let's talk a little bit about the neurophysiology. So basically you have a traumatic event that this is the work by Hans Selye. It produces a alarm reaction, and if it's a prolonged alarm reaction, it's going to alter the neural systems. Pierre Janet, back in the turn of the century, the early part of the 20th century, was one of the first people that talked about how this fixation, the altered neural systems create a constant state of hyperarousal that lasts a long time, and it could, and people that are traumatized seem to be fixated in the past and obsessing day in and day out about their trauma. They can't turn it off because it's kind of like the needle in the thermostat gets stuck on high and it won't come down. So this is the dilemma that we face with the treatment of PTSD, that the psychotherapies for PTSD work up here, but PTSD works down here as well. So a lot of the trauma and the dysregulation happens in the lower parts of the brain, and so we're trying to get the cortex to regulate the lower parts of the brain, and it can happen up to a point. And psychotherapies do work for PTSD, but we got to take into account that the trauma is also in the lower parts of the brain. Here we have Charcot. Remember that Freud went to study with Charcot in Paris at the Salpêtrière because Charcot was studying hysteria. And if you remember, the women at the time weren't allowed to go to school. They were very impressionable, and they weren't allowed to complain, so they had dissociative reactions. They had hysterical attacks. Sigmund Freud talked about that a lot of these conflicts were unconscious and so on. That was the beginning of the psychodynamic roots of understanding PTSD as well as other things. So we have the dichotomy of hyperarousal leading to a point of dissociation where the brain cannot integrate the intensity of the arousal, and then it disconnects, and then you get the dissociative states. So dissociation occurs as a defense against overwhelming stress or painful emotions, and it's in the orbital medial prefrontal cortex that we have the way station right here that connects the limbic system to the prefrontal cortex, and this is the part that's kind of the interpreter of the rational part of the emotion. So you have this back and forth dialogue. I feel this, what does it mean? Well, it means this, and I should control this, and so on and so forth. So our lives, as you know, are this dialogue between what we wish and what we want and what we feel and what we're allowed to have, and so on and so forth. So what happens when there's too much stimulation in the limbic structures, it disconnects from the frontal lobe, and then you get the amnesias and so on and so forth. So the stimulus overwhelms the system, and the experience cannot be integrated by the frontal lobe, does not get recorded and the limbic system overreacts, and then you get the amnesias. So other neurochemical changes that happen as a consequence of trauma. So we have the locus ceruleus, and the locus ceruleus is also connected with the rest of the autonomic nervous system, and it's run by norepinephrine and epinephrine, and it's responsible for the fight-flight response, right? So if you overstimulate the locus ceruleus, what you get is, again, you have a needle in the thermostat gets stuck on high, and it fails to habituate. It cannot come down. So what you get as a consequence of having this epinephrine and norepinephrine storm in the body is irritable behavior with angry outbursts, reckless self-destructive behaviors, hypervigilance, exaggerated startle response, problems with concentration, and sleep disturbances. So think about this in terms of how we're going to do the pharmacology. Here we have an example of an overstimulated locus ceruleus. So this is the Rambo movie. You know, he's like a typical PTSD individual who, you know, he's taking a nap and his girlfriend says, "Hey, Rambo, wake up." Ah! You know, he has to control himself to not strangle her, and then he's, you know, has these dissociative episodes and so on. Another thing that happens with trauma is decreased serotonin. So let's think about that in terms of the pharmacology. So the serotonin levels are below normal, so that causes increased impulsivity and aggression, and of course increased irritability. We know that the low serotonin gives us irritability, and increased obsessive and repetitive and rigid behaviors. So the SSRIs, which elevate the levels of serotonin, have been found to improve these symptoms in PTSD, although the research is scant. Here's another you know, media representation of PTSD, and Mel Gibson playing the detective in, what's the name of the movie?
Lethal Weapon.
Lethal Weapon, that's right. Lethal Weapon. As you remember, he has PTSD and he overreacts and he takes a lot of unnecessary risks and he's very reckless, and in the end, love cures it all. He finds the right woman and the PTSD gets cured. So the other thing that happens with PTSD is a release of endogenous opioids, which, as we know, is a stress-induced analgesia. So the person starts kind of anesthetizing themselves, and this can be triggered sometimes by exposure to traumatic reminders and so on, and it can also be pleasurable. And sometimes what happens is people get addicted to the adrenaline in dangerous situations, and this has happened a lot with war reporters. Sometimes the people who cover wars and combat situations, they love the danger, and after they finish their mission, they're sent home, but they want to stay because they get hooked with the endogenous opioids, presumably, to these, you know, very dangerous and probably very traumatic situations. So people who have PTSD sometimes seek to repeat these traumatic situations, and that may explain partially the sadomasochistic sexual perversions. Why do people experience sexual pleasure from pain? A lot of these individuals have been traumatized before, so that could be some of the neurophysiology. The human stress response. You're all familiar with the concept of allostasis, to bring back things to their previous shape. I guess the desire to create allostasis to you know, bring things back to their level. The individual who, you know, if you go to a party on Friday night and there's 20 people talking at the same time and you've had a difficult week, what you want to do is go out to the yard and sit down and look at the moon for a little bit to kind of, you know, bring back your allostasis. So what happens is with the stress response, it involves the autonomic nervous system it recruits the corticotrophin releasing system and as well as the hypothalamic pituitary axis. So when people are, I guess, exposed to chronic stress, they increase their allostatic load. And this can cause a neuroendocrine dysregulation. So if you go to a lot of the veterans hospitals, most of us have rotated through the veterans hospitals, we see a lot of people with PTSD, and what do we see? A lot of obesity, high blood pressure, hypothyroidism, premature cardiovascular disease, premature aging, and disorders of mood and behavior. There's also inhibition of neurogenesis and neuronal plasticity and cell atrophy, which I'll talk in a minute. The trauma also involves the glucocorticoids. So we have the hypothalamic pituitary axis here. And one of the things that happens with chronic stress is the release of pro-inflammatory cytokines. So all of us, when we're very stressed, you start feeling like pain in your back and pain in your arms. And from a Darwinian evolutionary perspective, apparently nature put that in there so that our body tells us, take a break. You know, you can't keep running at the same speed. So it starts giving you kind of physical pain. So like, let's say that like in the animal kingdom, a bear gets into a fight with another bear, ends up, mauled and so on. And the bear gets pro-inflammatory cytokines. So he goes into the cave and hibernates so his body can heal and he can recover. And so one of the ways that, and then, you see a lot of, if you have an increased cortisol level and, a high stress response that is constant and doesn't go down, you have all these other things that I mentioned before, the premature aging and so on. And one of the places where we see that is in American presidents. So think about presidents when they start, and if they get 2 terms, that's 8 years, they end up looking like they're 25 years older. Now this guy over here, he had all kinds of stresses, some of which I will not mention, but presidents do have a lot of stress when they're so another thing that we see is that there's temporary cell atrophy and cell death. The research is not very clear on this. It's not very clear whether it's permanent or temporary, but with some people who are chronically traumatized, you see the dissociative and blunting of affect. It's almost like they're empty shells of human beings. And this is what happens. It seems that some research shows that antidepressant medication can increase, can reverse some of this. And although the research is still, scant. Okay, the amygdala. So the amygdala assigns feelings to an incoming stimulus. And the signal then goes to the neocortex, which further elaborates and assigns an emotional meaning to the stimulus. So there's an integration of, the emotion over here, the feeling, and what the feeling means. And so, the connection between the amygdala and the frontal lobe has a lot to do with assigning meanings to emotions. And then the hippocampus, which is very close to the amygdala, is what puts the story together. So the hippocampus tells the story about the event. And one of the problems with children is the slow maturation of the hippocampus, which is not fully myelinated. It doesn't myelinate until the 3rd or 4th year of life. So that's why when children are about 3 and 4, that's when they start telling stories, and that's where you get narrative memory for the first time. And before, what you get is somatic memory. So what does trauma do? trauma interferes and it shuts down the connections between the amygdala, the frontal lobe, and the hippocampus, so the traumatized person is unable to tell a story about the event. They end up keeping the somatic memory in the deeper structures of the brain, but the narrative memory about the event does not get integrated. So psychotherapy, one of the things that psychotherapy does is put back the story, create a narrative of the event. So the work out of Israel, Tuval Masiak, she's done a lot of work with traumatized Israeli soldiers, and she says that trauma is a broken narrative, and that psychotherapy repairs the broken narrative. So let's see. Here we see some very traumatizing pictures of children. And so, as we know, children integrate trauma in an egocentric manner if they're at a young age. They organize the event around keeping secrets, and if left to their own devices, they end up with very serious deficits of self-regulation. So, okay, so then we go to what do we have until now in terms of like how to treat PTSD in children. The Academy put together practice parameters in 2010. So they're 8 years old. They have not been updated. So this is what the practice parameters say. They have a classification similar to the one that we're handling today. They have minimal standard, clinical guideline, option, and not endorsed, right? So minimal standard based on rigorous evidence, clinical guideline based on strong empirical evidence about, say 75% of the time. Kind of like in forensic psychiatry, the preponderance of the evidence. So this would be, and then option acceptable based on emerging evidence, but the evidence is still weak and of course not endorsed. So the first recommendation is psychiatric assessment should be done routinely with and should include some kind of questioning about experiences of PTSD. The recommendation 2, if screening indicates significant PTSD in the interview, the clinician should conduct a formal interview to determine whether PTSD is present. What is the severity of the symptoms, the degree of functional impairment, and should interview parents and other caregivers. Should be included in the interview. Third recommendation, the psychiatric assessment should consider differential diagnosis of other conditions that mimic PTSD. Recommendation number 4, treatment planning should consider comprehensive treatment, which includes consideration of severity, degree of impairment, etc. And this is all very logical, right? Treatment number 5, treatment planning should incorporate appropriate interventions for comorbid psychiatric disorders. And then here we start the real thing. Trauma-focused therapy should be considered as a first-line treatment. So the most evidence is with the cognitive behavioral therapies. EMDR is an effective treatment in adults, but there's very little evidence for children. And psychodynamic trauma-focused psychotherapies is what's predominating right now. Okay, this is our controversy, which we'll get to in a little bit. SSRIs can be considered for the treatment of children and adolescents with PTSD. Now, in our guidelines, they're not recommended. So that's what we're going to talk about, whether yes or no. So preliminary evidence suggests that SSRIs may be beneficial. So here's the deal. SSRIs specifically for PTSD, there's 3 open trials with sertraline and 3 open trials with fluoxetine. The 3 open trials with sertraline are positive, and the 3 open trials for fluoxetine, 2 are positive and 1 caused too much excitability and had to be discontinued. So 1 negative and 2 positives. Medications other than SSRIs can be considered in, such as anti-adrenergic agents, clonidine, propranolol, and so on. Anticonvulsants may show some symptoms, some improvement, and benzodiazepines have not been found to be beneficial. Okay, we're getting to the end here. Treatment should include school-based accommodations, things like kooky things like rebirthing therapies and things like that are to be avoided, and school and other based interventions for PTSD and traumatic events should be considered, but you have to be very careful because sometimes they can be detrimental. So that's what we have on PTSD. Thanks. Thank you.
Now we move to the guidelines.